Thank you for joining us for the Johns Hopkins Government, Community, and Economic Partnerships Showcase Series, which highlights different Johns Hopkins programs with a strong relationship with the state of Maryland. My name is Delegate Emily Shetty, and I represent District 18 in Montgomery County, and I serve as the chair of the Health and Social Services Subcommittee of the House Appropriations Committee. I will be moderating today's discussion. So today, we're going to be learning about an extraordinary asset in Maryland, the Pediatric Trauma and Burn Center at Johns Hopkins Children's Center. This is the only pediatric trauma and pediatric burn center in the state, and we are so grateful for their work. To educate us on the specifics of their work, we will be hearing from the Surgeon-in-Chief of the Children's Center, Dr. David Hackam, Director of the Pediatric Trauma, Dr. Isam Nasr, and Director of the Pediatric Burn Program, Dr. Erica Hodgman. The Johns Hopkins Children's Center is a 205-bed, state-of-the-art hospital with an expansive pediatric emergency department equipped with dedicated pediatric trauma resuscitation bays, a 28-bay pediatric intensive care unit, and a pediatric operative suite with designated emergency operating rooms for pediatric trauma patients. The Children's Center is also home to Maryland's only pediatric burn center, providing care from a multidisciplinary perspective, including specialists from surgery, psychology, physical medicine, and rehab, and child life experts, to name just a few. According to the Maryland State Trauma Registry, the JHCC treats nearly 1,000 trauma and burn-injured patients per year. Before we get to the discussion, I want to go over some logistics. This webinar will be recorded and will be posted to the Hopkins at Home websites, with captions included. Additionally, the questions and answers function has been enabled during this webinar. Please feel free to type questions in there. We will do our best to respond to as many questions as we're able to in the time that is available. With that, Dr. Hackam will be starting off the presentation.
Thank you so much, Delegate Shetty. And to my colleagues, Dr. Nasr, Dr. Hodgman, hello. From all of us here at the Children's Center, welcome. It's a real pleasure, a real honor to tell the story of the pediatric trauma and pediatric burn programs here at the Johns Hopkins Children's Center, and how every single day, large teams of us are here really 24/7 to take care of some of the most injured and really, quite frankly, badly burned children in our region and beyond. And this program, these burn programs, are led by these fantastic surgeon leaders, Dr. Erica Hodgman and Dr. Isam Nasr, and we'll be hearing from them in just a moment. In the next slide, I want to just provide a little more context regarding who we are and what we do. After that, Dr. Nasr is going to tell the story of our pediatric trauma program, its excellence, its outcomes, and its future. And Dr. Hodgman will shed light on our pediatric burn program, what a burn center is, how we're unique amongst children's hospitals to have a burn center that's nationally accredited, and the work that she and her team do every single day to take care of kids that are the unfortunate victims of those fires and those injuries that we hear every day in the news. The Pediatric Trauma Program is designated by the state of Maryland as a Level 1 Pediatric Trauma Center, which means that we have to meet the very highest standards of care. It means we have to meet the very highest standards of teamwork and the groups of teams that are available 24/7 to take care of these patients. And this didn't happen by accident. Two very important things occurred in order for us to reach our current designation. The first is MIMS, establish us as a pediatric trauma center in the 70s. But that wasn't enough, because at that time, the trauma program, as it was known before we were fully established, was in a relatively antiquated building on our campus, but a building that didn't have the facilities to meet the needs of our patients or our teams or our families. And so with the Maryland General Assembly, multiple governors, along with Johns Hopkins Hospital leadership, secured the funds to build a state-of-the-art tower. And at a cost of about $100 million per tower, this investment by the state of Maryland has resulted in the world-class program that we're going to be talking about today. So I really sit here as a proud Marylander and pediatric surgical leader, acknowledging the support from our state. The Pediatric Burn Program has similarly had a meteoric rise in its reach and its success. I'm delighted to report that very recently we were verified by the ABA, which is not a rock group, it is actually the American Burn Association. We were verified as a level 1 pediatric burn center. Only a handful of pediatric burn centers across the country meet the levels that the ABA demands for pediatric burn care. And we're all incredibly proud. And this is not a one-time thing. It requires constant vigilance to the maintenance of standards. And I would say we exceed those standards, and you'll hear that from Dr. Hodgman. We actually split from a very successful and state-supported and very proud adult burn program in 2012 when we moved into our new towers, because of the additional expertise that these towers allowed us to provide, specifically with a designated pediatric ICU. And as you'll hear, our quality improvement efforts are central to our care. In other words, we're always looking to make sure we're delivering the best care to the most children in the safest way possible. And so what does that look like? In the next slide, please. The children come to us in large numbers from many counties in the state of Maryland. And so just in terms of the number of patients, again, you have to ignore the news not to realize the amount of trauma that our cities are facing. And these patients come to our open doors. And our pediatric burn program similarly has seen an increase from fiscal year 22 to 23. And this map of our beautiful state shows the density of where our kids come from. And we're always here. And our transport teams are integral in getting these patients to us by land and by air. And so in the next slide, how are they injured? They're injured essentially in 6 large categories. And so you think of how a child should never get injured, but obviously children being children will fall, children going to soccer practices will get hit, and children riding their bikes or walking down the street, unfortunately, will get hit. And so falls and car crashes, that's what MBC stands for, and pedestrian stroke are the most common causes. And these are the other causes. And as you'll hear, we believe that our best success is when we can reduce injury from occurring in the first place, and you'll hear a lot of that. Burns, by contrast, occur largely through either scalding or flame or inhalation injury from fires or other irritants. And so in my final 2 slides, it is a source of tremendous pride to share with you the people that are not on the screen, that are every single day working to take care of these precious patients. And so these are our pediatric trauma and burn surgeons, but these individuals represent only the tip of the trauma spear, if you will, because we are supported in the next slide by a world-class team of healthcare professionals that, as was mentioned by Delegate Shetty, include child life professionals and include wound care specialists and include pharmacists, but also include psychologists and also include rehab experts, because we recognize, as you all do, that trauma affects not just the patient, but the family, and burns affect not just the patient today, but for the rest of their lives. And it is our job to make sure that these children lead those lives to their fullest potential. And so with that, it is a great honor to turn the floor over to Dr. Nasr. Dr. Nasr joined the Johns Hopkins Children's Center after training at the University of Pittsburgh several years ago and leads the pediatric trauma teams to distinction. Dr. Nasr.
Thank you very much, Dr. Hackam, and thank you, Dr. Delegate Shetty, for hosting this event. I want to start by saying that we are very proud of our programs, and we are honored to be able to showcase the trauma program and the burn program. And I want to thank Dr. Hodgman for the amazing collaboration, and thank the rest of the team, which we can't thank enough, the surgeons, the pediatric surgeons, and Dr. Hackam's support. We have a lot of administrative support and a lot of nurses and ancillary support staff that we'll kind of mention in a little bit. Now, to go back to why we are here, why is the Pediatric Trauma Center important? And that's in contrast to an adult trauma center, which they do a great job taking care of adults. And as Dr. Hackam mentioned, in the 70s, Hopkins was a pioneer. We had probably one of the first children's center initiatives to take care of injured kids specifically, and there was an agreement whereby Dr. Haller and Dr. Alex from Shock Trauma decided to split the two programs and allow us to take care of kids. And in the early 2000s, we started getting designations. So that's what this graph looks at here. Since the initiation of specifically trained pediatric trauma centers, we would see that we have excellent outcomes and we have lower pediatric injury mortality rates in the states that have pediatric trauma centers. And what that tells us is that children receiving specialized care for the injuries do much better. And this is what we're all about here. In the next couple of slides, I'm going to highlight a case, and I want to warn people that may have a trigger from any graphic pictures. I'm going to show some pictures of an injured child. So please be aware of the next few slides. But I wanted to do that because I wanted to give you a kind of snippet of what we deal with on a daily basis here and what we see to help these injured kids. This is a 13-year-old child that was riding his bike by the beach and was run over by a bus and dragged under the bus for several yards. This child sustained multiple internal injuries. He had a pelvic fracture, a rectal transection, and a very bad injury to his urethra, which led him to our hospital here in a very critical state. The troopers, I want to thank the troopers and the EMS staff that do a phenomenal job in stabilizing these kids, transport team that brings these kids over to us and do a lot of the work up front. And then to our emergency department physicians, who without them, we can't do this. This child received extensive resuscitative efforts in the emergency department and was eventually transferred to the ICU and the operating room, where he had multiple operations. And you can see here in the first picture, this is his pelvis. Basically, the inside of his his organs were exposed to the outside world, and he had to undergo multiple operations. His legs and extremities were degloved. He had to undergo multiple skin grafts. And please, next slide, please. And here, I just wanted to highlight the heroic efforts of everybody that was involved. And I think this list is probably missing a few people. The pediatric trauma surgery team, the emergency physicians, anesthesiologists, the vascular surgeons, the urologists, orthopedic surgeons, the ear, nose, and throat physicians, the eye doctors, and the nursing staff, physical therapy. This child was in the hospital for several months, in the ICU for several weeks, and more importantly, he was in rehab for a couple of months, and he was recently discharged. So thank you for the chaplains, the social workers who were. I remember when this child came to the trauma bay, the chaplains and the social workers were all over the family, trying to support them, trying to help them. Again, thanking the EMS and the troopers that helped bring the kid over here. Next child, please. And this, all good news. The child's doing well. He has healed. All his wounds have healed, and he is kind of halfway through. He will require multiple reconstructive operations, and he's in the right place. As Dr. Hackam mentioned, we are in one of the best hospitals in the world, and we have excellent urologists, orthopedic surgeons, plastic surgeons, and pediatric surgeons that will help reconstruct this child to bring him back to as close to normal as possible. And this is what brings us a lot of joy and a lot of pride to be able to see this child go back to school. He's been going virtual, so these are the small things that we look forward to and watching these kids heal. Next slide, please. So how do we achieve that? The trauma volumes seem like a lot. We see 1,000 trauma patients a year, but we have a big team. So we want to make sure that our team is up to date with our standard practices. We want to make sure that our team works well together, that they know how to function as a team. They know how to have closed loop communication. We want to make sure that our team is the best that we can provide to the children of Maryland. We want to make sure that we identify any issues that arise in the system. So how do we do that? Two things. We have a trauma and burn boot camp, which we started probably 4 or 5 years ago, and it's a yearly course. We do it. We have 4 sessions a year in the winter, and we bring together all the players in the trauma team: nurses, physicians, fellows, residents, and it's a didactic course. We introduce them to basic trauma and burn topics. We have simulation scenarios. We show them blunt, penetrating traumas, burns, traumatic brain injury. We have skilled stations. We take them through chest tube insertions, how to put a central line in, how to apply a tourniquet. So it's been a very successful course, and we every year we're expanding, and our eventual goal is to try to bring it to the community, to our emergency physician colleagues in the state. The other thing that we do is emergency simulations. On the right side here, you can see it's a dummy that we work very closely with the Sim Center at Hopkins, which is one of the best Sim centers in the country. They give us all their resources, and what we do is we once a month, and that was we did that yesterday. We page out a real alert. We say there's a real level 1 trauma or burn, and we surprise the team. We test the system. We test if we have the right equipment. We make sure that everybody is doing their role. We make sure that we change the scenarios very kind of on a very active basis. This way, we try to mimic real life scenarios, and we do a debrief afterwards. Dr. Hodgman did that burn yesterday, and she did a great job debriefing and learning from our experience. And this is how we learn from working together. Next slide, please. The next thing that I wanted to highlight is we had a mass casualty hospital-wide drill. Unfortunately, the way things are going in the world, in the country, we have to anticipate a mass shooting, an explosion, a house fire. We have to, or a big casualty event. So we want to report that we had a very successful mass casualty hospital-wide drill with the adult and pediatric centers, where we activated a hospital-wide mass casualty scenario. And I think we did a great job. We learned a lot, and we took a lot of notes. So I think you can rest assured that we are ready for any disaster that ensues in the region. Next slide, please. Stop the Bleed is one of our biggest. You may have heard of this. One of the biggest initiatives. We go to schools. We teach. We teach the teachers. We teachers in schools and the students. So I think you're going through the slides. Yeah, one more. Thank you. So Stop the Bleed is an initiative where we go over to the community and teach them how to apply a tourniquet, how to apply pressure to a wound. Anyone can be, just like CPR was widely popularized several decades ago. Unfortunately, we need to have something similar for a mass casualty event, and to start the resuscitation, start the efforts in the field by anyone that can physically perform this. So teachers, students, and we're happy to go to anywhere in the state. Please reach out to us, and we're happy to organize something local in order to teach the community how to stop the bleed. Next, please. We're very proud of the Survivors Day event that we hold annually with the adult side. And every year we highlight a trauma survivor. They tell us their story. It's usually a very moving story, and they go over the EMS, from all the way from EMS to their rehab care. It's a very touching ceremony, and kind of highlights the importance of what we do, and how we affect everyone in the community. Next, please. Injury prevention is one of our highlights, and this, as everything else, is shared by the Trauma and Burn Centers. And please, Dr. Hodgman, feel free to chime in later about this. Injury prevention is key. Our goal is to have 0 injuries, go from 1,000 injuries a year to 0. We all know that's impossible, but we try. We try to go out in the community. We have several services. On the left side here, we do car seat fittings. You'll be surprised on how many kids are in the wrong car seat. You'll be surprised how many kids are riding bikes without a helmet. So we distribute helmets, we measure helmets, we do education, we do a lot of public safety events, we do home safety education, we do school visits, and also we do research. We try to see how we can improve. We have a great public health school at Hopkins, and we collaborate very closely with them. We have our injury prevention education. We have excellent injury prevention staff that go around doing these car seat safety, falls prevention, poison prevention, distracted driving, and safe firearm storage. All these initiatives have reached the community of throughout the state of Maryland, and I think there is room to do this a little bit more and to expand our services to more areas in the state, to more rural areas.
I hope for those that are listening that you get a sense of how Dr. Nasr's team is focused not just on treating the injured today, but restoring them to full health for tomorrow, so that these kids can get on with their lives that are also impacted by burns. And we're very fortunate that Dr. Hodgman joins us as the director of our Pediatric Burn Program. As I mentioned today, just a handful of programs that proudly has been accredited by MIMS, our state agency, and also by the American Burn Association. Dr. Hodgman joins us where she, after completing her training both in Memphis and at the very famous burn program and surgical programs at the University of Texas Southwestern. Dr. Hodgman.
Thanks very much. I am sort of echoing what Dr. Nasr and Dr. Hackam said. I am very proud to be here and to present our burn program. It is a truly extraordinary program, just because of the depth and breadth of people across the hospital who touch on these patients and help us to really provide excellent care for them. I think, as Dr. Hackam mentioned, we are one of the few children's centers that has its own dedicated pediatric burn program. And I think part of what makes us so special is not only can we take care of the physical injury to the child, but we can really take care of the whole child in a way that is developmentally appropriate. And also to help provide a lot of compassion and support for their families as well. Because when these injuries happen, they are extremely stressful, not only for the patient, but also for their families who have to, watch them go through their recovery, watch them go through daily dressing changes, which are quite painful. And so it's truly an honor to be a part of this team and work with the people that we get to work with on a daily basis. So this is a good example of a patient that we recently took care of. This is an 8-year-old who was actually in the back of her father's food truck when they were hit by another car and the fryer spilled boiling hot grease all over her. You can see she has injuries to her scalp. Unfortunately, she had long, beautiful dark hair, and we had to shave her head in order to be able to clean up her scalp burns. She had pretty significant injuries to her arm and as well as to her torso. If you can go to the next slide, please. During the course of her hospitalization, we had to bring her to the pediatric intensive care unit where she had fluid resuscitation and pain control. Over the course of the next several weeks, she went to the operating room several times with both the pediatric surgery team, the burn team, as well as plastic surgery to work on her face. Anesthesia had to work very carefully to figure out how to properly secure airway devices, given that her face was burned. We had to work a lot with her with child life, both to help cope with her really painful and stressful dressing changes, as well as the obvious really big impact on her appearance. She was very upset about her appearance, the loss of her hair, the burns to her face. We also worked very closely with the psychology team who were seeing her and her family every day to support them and help them cope with this. The nutrition team, burns are actually one of the most hypermetabolic injuries that you can have. Kids lose a lot of lean muscle mass. So working with the nutrition team to make sure that she has all of the nutritional support that she needs, the pharmacy team, the pain service, very obviously, as she's going through skin grafting, physical and occupational therapy, and an absolutely enormous number of nurses in the ED, in the PICU, and on our 10 South burn unit who took truly excellent care of her and loved her like their own. If you can go to the next slide, please. So she actually did really, really well. She's home now. She's already gone back to school. In the future, she's going to need additional PT and OT in order to ensure that she's got great range of motion. She has already been referred out for compression garments to help soften and smooth the appearance of her burn scars. Eventually, she's going to need laser scar therapy, again, to help soften and smooth things, improve the appearance, and also improve her function and range of motion. She's having ongoing psychology support for both her and her family. And then we also work very closely with several burn camps and other programs around in the Mid-Atlantic region. So she can go and be with other kids who have similar burns. And these burn camps are really exciting because they kind of get a moment to be around other people who've been through what they've been through. They can, if people want to learn how to do makeup over burn scars, they can learn how to do that. They can do archery and equestrian activities, go swimming, and all kinds of really fun things. And that really helps them to reintegrate and to get their childhood back. And so I have a little brief video. Our little friend here actually, before her injury, was really into TikTok dances. And so as part of her physical therapy, our team did a TikTok dance with her and recorded it. And I think she may have put it up on her YouTube, but just to get a sense of really the difference between what a regular old burn center can provide and what a children's burn center can provide. I think this really highlights it and is frankly really adorable. So yeah, so like I said, it's great physical therapy too. It's really helping her work on her range of motion in that shoulder. And sort of similar to what Dr. Nasr mentioned, we run an annual special topics in burn. We call it the State of the Burn Program, which we invited nurses, pediatrics residents, emergency medicine residents and faculty from around the Hopkins hospital system to talk about various topics in burns. This year we highlighted burn-like skin diseases. We also highlighted inhalation injury. We had several hands-on stations where people could learn how to do a proper burn debridement, a burn dressing, and could also learn about some of our more advanced wound care techniques. One thing that we're really excited about is a product where we can actually take a small portion of a patient's own skin cells, solubilize it and turn it into a skin cell spray, basically, and spray it back onto the wounds to help them heal faster and repigment faster, which is really exciting. And so it's really quite an honor to be able to show everyone from around the Hopkins system kind of what we're up to, where we're going. And we look forward to hopefully inviting people from outside the Hopkins system next year, again, to further expand our educational reach. And so we were sort of asked where we think the future of the pediatric trauma and burn programs are going. And Dr. Nasr and I put our heads together, and really what we want to do moving forward is we want to step even further into the spotlight and become a resource for the entire state of Maryland. So we are working very hard to improve and increase our community outreach, become more integrated in the communities, not just in Baltimore City, but around the state of Maryland, to expand our injury prevention efforts, to expand surrounding hospital education. You know, how do you take care of a minor burn? How do you assess a trauma patient? How do you stabilize a trauma patient before our expert transport teams can come and get them? We also want to expand our survivorship support. We have really great teams while patients are inpatient, in terms of child life and psychology support, as we've highlighted to you. But it becomes a lot harder to keep that support going once the patient leaves the hospital. So we're really hoping to be able to recruit more child life, more mental health professionals in order to be able to continue that wraparound support and help ease the transition back into regular life. I think Dr. Nasr will probably talk about this a little bit more, can expand on this more, but we're really hoping to expand or establish a pediatric violence intervention program. Most programs around the state take care of patients that are 15 years and older. And as you can tell, a lot of our patients are younger than that. And unfortunately, they do experience occasional episodes of violence. And one thing that we know is that hurt people hurt people. And so if we can intervene while children are just after their injury, help, wrap around support services to them and their families. Hopefully we can help to break that cycle and reduce violence in the future. And then we're also hoping to expand our research and clinical, both clinical and basic science research in the future to improve outcomes for all of our patients.
Dr. Hodgman, thank you for the incredible work that you and your teams do every day and for that presentation. Before I return the floor to Delegate Shetty, if I could just say, I think I share with everybody how fortunate we are and how humbled I feel to be part of this burn and trauma program. And also how incredibly lucky we are to have the support of Delegate Shetty to prepare this today. I just want to highlight 4 points that I think were made. First, we're here 24/7 to provide incredible expertise. Second, our programs have achieved national recognition. Level 1 of the trauma program, ABA for the burn program, these are very difficult to get. They're very, very rigorous, and they provide national recognition. So Marylanders need to know that they have the best care in the nation. Third, the focus is not just on the patient, but on the entire family, and not just today, but tomorrow and the day after, so that our kids and our families are restored to full health, so that they can get on with their lives and be productive, happy members of our communities. And then finally, and Dr. Hodgman said it best, we treat our kids like they are our own family. And all the data in the world that supports the importance of trauma and burn programs can never capture that. I think the TikTok video did. But if you were to see our nurses and our doctors and our therapists working together, you don't just feel hope and you don't just feel expertise, you feel love. And that's why we're all here today. So thank you very much. And it's just a great honor to be part of this. And back over to Delegate Shetty. Thank you.
Thank you, Dr. Hackam, and thank you, Dr. Hodgman and Nasr, for your presentations, but most importantly, for the important work that you're doing every day with your patients. It's really one thing to hear about the work in a little room here in Annapolis, and it's a whole other experience to really get to witness it and understand it from the perspective of the sweet child who's dancing and all that the team's efforts have meant to her. So thank you for sharing that. I want to ask a couple of quick questions before we open it up to any others. You share here on our slide that you have this future vision of what pediatric trauma and burn care could be here in Maryland. But it seems to me that the program has already had a deep impact on our state. Can you please share a little bit more about that?
Yeah, so maybe Dr. Hodgman, what is the impact on the state and what is the vision for the future? Maybe those together. And then Isam. Erica, what do you think?
Yeah, so I think we are already being recognized as a resource. So we get phone calls, sometimes even in the middle of the night from hospitals all over the state of Maryland to say, oh, I've got this little burn, can you please just tell me what I need to do for it? Or can you please help me arrange, outpatient follow-up, which, we're always very happy to do, to, oh my gosh, I've got this huge burn. I'm very stressed about it. I don't know what to do. And we'll walk them through that on the phone too. And we'll send out our transport team to go pick them up and bring them down to us. So it's, sort of helping, teams in the community care for patients where they are. And if that's all they need, then that's great. And if it's helping to bring them to us, then that's great. We're trying to expand our support to families, in farther flung parts around Maryland. It's not always easy to get from, for example, the Eastern Shore all the way over here. So we're working on ways to help expand our outreach and our support to families sort of where they are, meet them where they are.
Yeah, that's absolutely true. It's very broad. And people probably don't realize that the phone calls are a big part and the connectivity to ERs across the country, because across the state, because kids go to their closest hospital. That's what we want. And their docs will contact us about their care. Isam, is that also true for trauma?
Absolutely. Yeah. I mean, our reach goes all the way even to Pennsylvania and to our adjoining states. So not only do we cover all of Maryland, we are a resource to neighboring states, Pennsylvania as needed, New York, sometimes Virginia. And I want to add one more, big impact to answer your question, Delegate Shetty, is, the research. Not only are we, applying these, principles, but we are trying to improve on these principles, and we're trying to, cutting edge research to disseminate to not only to Marylanders, but to the nation, and to try to improve how we resuscitate trauma patients and burn patients, and how to work better as a team. So all these efforts that we highlighted, like the boot camp and the simulations that we do, we study our work, we do research, we scrutinize everything that we do, and we look at the impact that we have. And we have found that there is a statistically significant impact on outcomes that we usually present in national meetings and conferences.
I mean, that's truly incredible and not surprising. Johns Hopkins has long been a leader in many areas of medicine, but very exciting to hear about the work that you all are doing here locally in our state that then is able to be used to support patients across the country and possibly world. So that's wonderful. Can you share a bit about what state policies and resources have made the program more successful?
Maybe Isam, continue from a trauma point of view where you're really impacted by state policies, and then burn subsequent.
Yeah, absolutely. Yeah, we work very closely with MEMS, and we're all familiar with what MEMS is. MEMS is the state agency that verifies us, and we not only get verified by them, but we work with them very closely to maintain verification, to make sure we work with the adjoining hospitals, we work with the EMS providers, we are very grateful that we have a Maryland's Physicians Trauma Fund, which I think started early 2000s, and that provides the on-call costs for the physicians that take trauma call, equipment grants, and helps with uninsured trauma patients. So this is one thing that I think the way it's paid for in part is taxpayers and through the driver's license. There's a fee that everybody pays, and that's something that we as a trauma center have benefited immensely from. And there are other numerous resources that are available to us via MIMS that we work with.
How about on the burn side, where perhaps there are some differences?
Well, I was also going to say, through MIMS, we've applied for and received grant funding to work on our Stop the Bleed initiatives as well. And so that's outside of the Physicians Trauma Fund. We really appreciate support from MIMS as well. The burn side is a little bit different currently. To the best of my knowledge, burn patients are not actually counted in the annual patient census when calculating the annual support for the Physicians Trauma Fund. So if you did the math, that's about 25% of the patients for both burn and trauma actually don't get counted in that allotment. But we do receive additional support from MIMS, and we, as Dr. Hackam mentioned, we are verified by MIMS. They come by every 3 years. And we do work really closely with them to work on policies around the state.
That's really interesting insight you just shared around burn patients. I'd love to explore that policy issue with you all offline afterwards, because that is the first time I'm hearing that. So it's really interesting. Thank you for sharing. What are some additional state policies or resources that might be needed to further enhance your positive impact here in Maryland?
Such a great question. How, Erica, can we do more, and how can the state help?
I sort of alluded to this on the last slide, but I think where we really want to go is we want to expand our survivorship support, and we want to establish a pediatric violence intervention program. And I think additional support from the state could really be instrumental in creating a program that not only serves the patients that we care for here at Hopkins, but also pediatric patients from around the entire state. If Hopkins doesn't have a pediatric violence intervention program, I can assure you that nobody else in the state does. And I have seen, even just in my own clinics, young teenager who has a gunshot wound that's slowly healing, and they come to me for wound care, and they don't really have anywhere to turn for psychological support, for social work support, for things like that. The families a lot of times want to move or don't feel safe in where they live, or the child expresses concerns about going back to school, and everyone's sort of looking at them and knowing that they've been shot, things like that. And so I think additional support services for our pediatric patients, I think, is really where we can make our next biggest impact.
And on trauma? Thanks, Erica.
Well, that kind of was trauma.
Yeah.
I answered for Isam, I'm afraid.
So yeah, no, I mean, we have I echo. I mean, obviously that's the adult side has a hospital violence intervention program. We are working with them, but I think it's the key thing is to have a centralized statewide, because these kids that are affected by gun violence don't only come to us, they go to other hospitals, other emergency medicine facilities in the state, and they grow into adults within a year or two, and they go to the adult hospitals. So we need continuity of care. And unfortunately, we are seeing more and more younger kids 11, 12-year-olds that are not just bystanders, but also actively involved in the gun violence. So we do need to focus on these policies. We do need to follow these kids throughout the healthcare system to any hospital they go to and offer them support and continued care. The other thing I want to highlight is, child protective services and child abuse. We have a great child protective services team. I think we can also, there's room for improvement on a statewide level where we can provide more support and help us expand our program to provide better services to these families and to identify kids that are affected by child abuse or non-accidental trauma, what we call it, and to provide the required foster care services and social services that they need. I think there is some room for improvement there also on a state level. I think we do a great job capturing them, treating them medically. Well, we need to kind of take it a step further.
That's a great flag, actually. I'm wondering if you know, or if you all have plans, whether you're currently or whether you have plans to partner with the child advocacy centers across the state. So if a patient is located actually in Montgomery County and is flown by way of the trauma network up to you all for care, and it has come to light that the child is a victim of domestic violence. Are you working with the child advocacy centers to help support them on the legal side of their needs?
Yeah, so that connection is, obviously is very, very complex. We have our social workers, we have our CPT team or child protective services team here that works with the appropriate state services, and we occasionally testify or we provide our insight or legal testimony to those services. But we work closely with our social workers and our liaisons. But I think again, our resources are stretched from our side here, and I think we can definitely use more people that can do exactly what you just mentioned.
Sure. Yeah. That makes sense. Man, there's such a great network and partnership opportunity there, especially since your team already has embedded social workers and others that are partnering with the families and with the young person in particular. To me, that type of partnership with our child advocacy centers could help potentially alleviate some of the stress that your team may be facing as well, as some of those resources are also available in our child advocacy centers, but they partner closely with law enforcement and investigators who may need to bring a case to trial, for example, if needed. So thank you so much. It's really, really helpful. I have one last question, and it's whether there are any models or services in other states or cities that Maryland and Hopkins Children's Center might want to be considering adopting.
So let's maybe each sort of take a crack at that, because we're always looking for ways to be best in class. And I know Isam and Erica's first point would be, well, they come to us to learn what we do. But there's always systems. And as Erica and Isam are sort of formulating the answer, it should be noted that the Children's Center, or the Johns Hopkins Children's Center, is unique in that we are an integrated center, in that we are a pediatric hospital and an adult hospital within the same complex. And so that offers us unique aspects, because we have an adult service that we can rely on. It's also so for certain types of procedures that are just performed more commonly in adults and rarely in children, we have an adult expertise. And also we have expansion beds if we need it in both directions, for mass casualty and a mass influx of patients. So that's a bit of a unique system as compared to other trauma and burn centers. That gives us unique advantages. But it also means that for the pediatric patient, the burnt child, the injured child, we really have to make sure that their voice is amplified, that their needs are met, that we are not treating them, quote, just like adults. And so we do look to our, what we call integrated hospitals at the system level, the hospital level, for opportunities to learn how to do that, how to maintain a pediatric specialty within a much larger adult complex. And so you could look at any integrated hospital like ours that offers pediatric trauma care, and we're in constant communication from a resource, from a staffing, from a policy, from a medical board point of view. So it's a really, really good question. Isam, are there additional thoughts? And then Erica?
I think we covered a lot of, in terms of your question is, are there any other models in other states that we can adopt? I mean, the short answer is, we can improve on everything. That's our goal, is to every day go over what we have and how can we do better. That's why we go to meetings. Like in November, there's a Pediatric Trauma Society meeting where we go and share all these ideas nationally and discuss what we can do better. And that's where, ideas for simulation, the boot camp course, we inspire people, they inspire us. But, the short answer is we are all verified by either a state or the American College of Surgeons, and they're all very rigorous processes that are very similar. And if we don't meet those requirements, we will not be a level 1 trauma center. So we all have the core principle of things that we do very similarly, but there are things that distinguish us from others and distinguish other places, which is research and how to improve and how to make changes in the current system, how to make changes into the current verification process. How can we do better? I think we highlighted a lot of the things that we talked about: injury prevention, talked about the violence intervention programs, and the child abuse protection services. And these are things that we have a great, core, but I think there is room for us to grow even more and follow some other models.
Yeah, and
but Erica, chime in.
Burn the same.
Yeah, so kind of piggybacking on that, for the burn program, we are actually a part of a multi-institutional collaborative called Pickwick. And we actually meet once a month. We do sort of an M&M where we go over difficult cases and share feedback. We do multi-institution research. So we combine our data together to try to get better power, or to look at more rare diseases or more rare, injuries, for example, in order to help improve care across the country. We also are just looking at sort of establishing benchmarks, just because, like I said, taking care of kids with burns at a children's hospital is actually kind of a rare thing. And so we want to establish benchmarks across the country. What does it mean to do the best? What is the, optimal time between their presentation in the ER and time to get their first pain medicine? What is the optimal time to do your first debridement? How, what's the optimal dressing? What does the optimal burn team look like in a hospital? That sort of thing, just establishing those benchmarks to help raise the level of care that's happening across the country, and also to look outside too and say, are other people doing things that we should adopt, that we can be doing better? So it's just sort of always looking around and saying, what are we doing really well? What can we do better? And how can we sort of push everyone forward?
Truly terrific work. So thank you so much for taking your time this afternoon to explain this important piece of the healthcare system. We're so grateful to have this resource here in our state of Maryland. I also want to take a moment to thank those who tuned in to listen to the conversation in the Showcase series. Johns Hopkins Government, Community, and Economic Partnerships team will host more of these events in the future, highlighting the anchor institution's relationship to our state. For questions, please email gcep@jhu.edu. Thank you so much for joining us.